that was published in New England Journal of Medicine by Dr. Christian Guilleminault from Stanford, where he noticed that at the transition from non-REM to REM, in a young, healthy 20-year-old, he saw a 9-second pause, enough to scare anyone, probably, and particularly in this particular subject who was otherwise pretty healthy. And because anything more than a 3-second pause, we call that as asystole, and a 9-second pause is something that could be seen in some healthy subjects, particularly even in normal healthy subjects, particularly if they have a robust autonomic nervous system activity. So this is just to summarize something that we've talked about so far, where when you have, particularly in REM sleep, when you have surges in blood pressure and heart rate related to increased sympathetic drive, along with maybe some underlying cardiac history to begin with, that then tends to lead to cardiac ischemia and arrhythmia. And this is one of the reasons why you tend to have subjects with underlying heart disease might be at an increased risk for sudden cardiac death, particularly during the morning hours. And I'll show you this slide in a second in the next few minutes here. So changing gears, let's talk about sleep duration and sleep depth. And this is a consensus statement that came out from the American Academy of Sleep Medicine and the Sleep Research Society in terms of how many hours of sleep that we all need. And this is based on 15 sleep experts using a modified brand-appropriate method. And for time's sake, I'm just not going to cover that, and it's actually listed in your slide booklet in terms of what that brand method was. And it's a way to establish some consensus there. And based on that, the consensus statements goes as follows: that adults should normally get about 7 to 8 hours of sleep per night on a regular basis to promote optimal health. And if one gets less than 7 hours, then there's an increased risk for weight gain, obesity, diabetes, hypertension, heart disease, and stroke. So particularly if you're looking at cardiovascular disorders, anything less than 7 hours might be placing people at a higher risk for this. And this is again, even though it's a consensus statement, this statement also reflects a little bit in terms of what the literature has indicated so far for us too. And also, getting less than 7 hours of sleep also impairs your immune system function. And so particularly for folks, and I usually use this as an example for my PCCM fellows and sleep fellows as well, because when they get their flu shots, I tell them to make sure that they get enough hours of sleep. And there's good studies that have shown that lack of sleep prior to your vaccination can depress your immune system response to the vaccination. So if you really want to make sure your vaccination is pretty effective, make sure that you do get enough hours of sleep before and after the vaccination shot, because it tends to help with your immune function. And also there's evidence to show that the pain threshold gets altered in patients with decreased amount of sleep, along with impaired performance, motor vehicle accidents, of course, and increased errors, both in terms of at least in terms of what happens in our job. More than 9 hours of sleep from this task force, based on the consensus statement, states that this may be appropriate, at least for young adults or individuals who are recovering from sleep debt. So if somebody's been sleep deprived for a while, then it makes more sense for them to have more than 9 hours of sleep. But otherwise, if somebody is actually sleeping 9 to 10 hours of sleep on a regular basis, if you exclude all of the factors, then that might be something that might suggest an increased risk for cardiovascular disease. And this is a complicated slide in the sense that it's not just a cross-sectional shot at how many hours of sleep a patient or a subject is getting. You just might need to keep in mind the society, the social level and the individual level in terms of determining the reason and why they might be getting the number of hours of sleep that they're getting. Because if you include all of those factors and then they're still getting less amount of sleep, then that puts them at risk for all these cardiovascular risks and then subsequently increased mortality. A good example is something that I'm doing right now in terms of vacationing. Normally I get about 7 to 7.5 hours of sleep. Here, because of issues maybe related to these two factors, I've been eating probably a little bit more more junk food than I normally do, and I've been getting, or I'm ending up sleeping more than 8 hours right now. So, which may not be a good thing. If one looks at it in a different angle, getting 8 to 9 hours of sleep may be a good thing, but if you put it in context of what related to these factors, that may not be a good thing for me at this stage. So whenever you're asking people in terms of how many hours of sleep that they're getting, the recommendation is 7 to 8 hours. If it's above or below, you may need to keep that in context with these factors before you attribute risks to cardiovascular disease and thereby subsequent mortality. I hope that makes sense in terms of what I just talked about. This is a slide that again comes from the same position paper that talks about the optimal dose of sleep model as well as the sleep saturation model. The sleep saturation model is here, which is this orange line out here, basically shows that the odds of insulin disease tends to continue to go down as they get more hours of sleep. This is a model that will be applicable for people who are actually having sleep debt and they're trying to recover from it. So that would be this particular model here. While all others, we end up following this U-shaped model where less hours of sleep might be putting us at increased risk for cardiovascular disease, and the optimal duration being between 7 to 8 hours, and anything beyond that, again, the U-shaped curve puts us at a higher risk for cardiovascular disease. And in fact, there's data to support this, and this is just one example that I thought I'd show you. This is a study that looked at incident coronary calcification based on both actigraphy as well as subjective sleep report in terms of duration of sleep, and almost follows a U-shaped curve here, where less amount of sleep, the odds for increased coronary calcification was higher, and that tended to drop as one gets enough hours of sleep and starts to go up as the number of hours of sleep actually starts going beyond the 8 to 9 hour mark here. Okay, so now let's look at obstructive sleep apnea. And I think we all know this pretty well. When you have an apneic episode, the apneic episode is associated with hypoxemia. And each of these events that tends to occur during obstructive sleep apnea leads us, because of the pathophysiology, leads to cardiovascular diseases. And one is hypoxemia because of the desaturation that tends to happen with apnea. And the increased sympathetic drive that tends to occur also, along with the arousal that tends to happen following an apneic episode, leads to increased heart rate variability. And also increased effort, the abdominal paradoxical breathing that tends to happen when one has an apneic episode also leads to cardiovascular consequences, and we'll touch upon that here in a second. And the arousal, as we talked about, because of increased sympathetic drive, leads to heart rate variability. And the reoxygenation, when we start rebreathing, and the periodic hypoxemia followed by reoxygenation also causes increased radical formations to happen that also increases risk for cardiovascular diseases too. So for time's sake, I'm just going to concentrate on a few of these factors. The hypoxia, not necessarily talk about hypercapnia, which tends to happen if the apneic episode is pretty prolonged. The increased arousals following all these apneic episodes that leads to increased sympathetic drive and heart rate variability, and also the increased intrathoracic pressure. This is an old study, but still pretty relevant in terms of what actually happens when you have an apneic episode followed by hypoxemia. So as you can see here, with each apneic episode that tends to happen, you have hypoxemia. And with these hypoxemic episodes, you see an increase in blood pressure. Of course, if the apneic episode is pretty long, the hypoxemic episode might be a little worse. I mean, you have significant hypoxemia compared to the hypoxemic episode out here. The rise in blood pressure tends to be worse, saying that hypoxemia per se, depending on the degree, can make your blood pressure to go up even higher for that particular apneic episode. This might be one of the reasons why in REM sleep, because your apneic episodes tend to be a little longer, followed by significant hypoxemia, you're more likely to see acute rises in blood pressure and acute changes in your heart rate variability in REM sleep compared to non-REM sleep. Also, hypoxemia can put people at risk for ischemia, and a combination of the previous factors that we talked about, coronary ischemia is very unlikely to happen during this particular state as well. Hypoxia also causes pulmonary vasoconstriction, and as discussed in the past by other speakers, it also leads to pulmonary hypertension. Because of hypoxemia, you can get carotid body stimulation, and that leads to increased sympathetic activity. And increased sympathetic activity in the context of what, with other factors that's all going on, can also increase one's risk for cardiovascular diseases too. This is again another elegant study done by Brent Summers, looking again at a microelectrode that was placed in the peritoneal nerve, looking at normal subjects and obstructive sleep apnea patients, and looking at the sympathetic drive, and then looking at the blood pressure at the same time. So these are normal subjects who have normal breathing pattern, and you can see the sympathetic drive at least is not too bad out here, and this is the blood pressure reading. In an obstructive sleep apnea patient, when you have an apneic episode, you can see a significant increase in sympathetic activity. And along with it, you can see the increase in your blood pressure, particularly when there's an arousal following an apneic episode that could potentially, when continued for a period of time, it can lead to consequences. And in fact, the previous slide showed something that was happening while one is sleeping, and it doesn't just happen only while sleeping, this translates into even during wakefulness too. So these are normal subjects where when looking at the sympathetic neural activity, you can see in a few of these subjects, the baseline is out here, but in obstructive sleep apnea patients, they tend to be carried over during the daytime. And that's one of the speculations and postulations in terms of increased blood pressure in these patients even while they are awake. What about intrathoracic and cardiac pressure gradients? And we talked about increased effort of breathing against an apneic episode that can cause problems. And this is just to show you an example in terms of what might actually happen. So this is your trachea, heart in a box within the thoracic cavity. This is the pleura. This is your left ventricle, and the normal left ventricle and systolic pressure is usually around 120 millimeters mercury. The chest here is actually the pleural pressure, so when we normally inhale, our pleural pressure is around -5. So the transthoracic pressure gradient, the transmyocardial pressure gradient, the pressure across the left ventricle to the pleura is 120 minus or -5, and that's 125 millimeters mercury, and that's usually the pressure that's exerted on the aorta, which is a reflection of your afterlobe, and that's the pressure that's also exerted on your left ventricular free wall. However, when you have an obstructive apneic episode, right during your apneic episode, as we talked about your effort of breathing increases significantly, right? Because you have an obstructed airway, the pleural pressure now becomes even more negative, into the -20, -40, and sometimes even -80 has been recorded. When that happens, your transmyocardial pressure gradient, the pressure difference between your left ventricle and the pleura is 120 minus or -80. It becomes 200 millimeters mercury. And that's a reflection, as we talked about, is your afterload. And so, not surprisingly, these patients are at risk for hypertension, but also a sudden increase in your afterload with an increase in your transmyocardial pressure gradient and a stretch that tends to happen here puts this at risk for ischemia. And also because the stretch is in this direction, the atrium also tends to dilate, making people at higher risk for atrial fibrillation too. So another reason why even one may not be necessarily hypoxemic, if you have an apneic episode that's long enough to cause these intrathoracic pressure swings, then you're more likely to be at higher risk for some of the cardiovascular events that we just talked about. So this is a summary slide in terms of what actually happens during an acute apneic episode. These are some of the intermediary mechanisms in terms of what could be happening that leads to cardiovascular diseases. So there's good biological plausible mechanisms by which how an apneic episode can lead to these issues. And when you have biologic plausibility, then the likelihood is any study that shows a positive response in that direction might then suggest that there's something that we may need to believe when data starts to come in that direction. And in fact, I will go about talking about that a little bit here too. And it's also important that as we look at these studies, association doesn't increase, it doesn't suggest causality, particularly if it's an observation study. And that was something that you would see in most of the studies that have been done related to cardiovascular diseases and obstructive sleep apnea. They will all be mostly observational studies, and that's something to keep in mind. And also, the risk factors for both cardiovascular disease and obstructive sleep apnea are similar, and so the confounding variables tend to be present, and that's something to keep in mind when looking at these studies, such as obesity, more common in male than females, and advancing age. The case control method, and we talked about some of the issues related to lack of randomized controlled trials, but it is what it is, and I think we just have to take it with that face value and look at these studies closely to see what we can make out of it. Also, I think this has been discussed for a while as well, AHI, the apnea-hypopnea index, so this is the best metric that we have currently. It's not it's an imperfect metric, and if it's something that you're looking to see if it increases the risk for cardiovascular diseases, it may not be the best metric to go by with, but it is what it is. And we talked about issues related to the observational studies. And another point to keep in mind is some of the effects that we see from obstructive sleep apnea and cardiovascular diseases, even though treatment may not be modifiable because some of the end effects might have happened when vascular remodeling tends to happen, and any treatment that tends to correct the stressor, but with ongoing vascular remodeling may not completely revert back to normal. And so those are factors just to keep in mind when you're looking at some of these interventional trials with CPAP as well. So let's start with hypertension here. And this is just a general slide to show that hypertension, systemic hypertension, tends to increase with age, and that's what's listed on your x-axis here. As we all age, the risk for hypertension increases both in men and women, and there are 60 million adult hypertensives in the US, and the majority of these hypertensive folks are actually uncontrolled, and some of them actually still undiagnosed as well. So 25% of the patients with hypertension have obstructive sleep apnea, and good data clearly shows that. And 30% of these hypertensive men had sleep apnea with an AHI more than 10 per hour. And this is in comparison to the controls where they had only 9%, where 9% of them had obstructive sleep apnea. 83% of the patients with uncontrolled hypertension, this is where they were using more than 3 antihypertensives, have obstructive sleep apnea. So if you have patients with uncontrolled hypertension, the likelihood of you making a diagnosis of obstructive sleep apnea is going to be high. The other way around, 40% of obstructive sleep apneas have hypertension as well. So it's almost a bidirectional flow in terms of the prevalence of obstructive sleep apnea and hypertension in each group. And if you look at the response sleep cohort study, there's a threefold increased risk of incident hypertension over a 4-year period, and this is independent of other risk factors that we talked about in the previous slide. And if you look at the sleep health study, the odds ratio is about 1.8 to 2 for hypertension. And as we talked about, there's tons of observational studies that suggest a link between obstructive sleep apnea and hypertension. And at least when you do an acute intervention with CPAP, it does reduce blood pressure, and I'll show you a few slides related to that. Of course, the bigger question is, does the effect of CPAP then translate into diurnal reductions in blood pressure? Because that's exactly what you want to do, or at least you want to see in these patients. And we'll touch upon a few CPAP interventional trials, and then move on to the next cardiovascular event here. Best way, of course, to look at the data closely is to look at the meta-analysis of all the studies that have been done. And this is just a study that shows all the studies that have looked at the blood pressure reduction with CPAP. And as you can see out here, it crosses the line where CPAP tends to favor a reduction in blood pressure about a couple of millimeters mercury. And just something to keep in mind, even a 2 millimeter mercury reduction in blood pressure has a significant effect on cardiovascular events, and a normal blood pressure pill, an antihypertensive pill, reduces your blood pressure by about 3 to 4 millimeters mercury. So a 2 millimeter mercury difference is still a significant clinical effect from any of these trials on hypertension. And just to look at a couple of these studies here, this is a randomized controlled trial looking at 1 month of CPAP versus subtherapeutic CPAP, and this is the baseline out here. You can see the dark circled ones are patients who are on CPAP, while the open circle ones are subtherapeutic CPAP patients. And at 1 month after being on therapeutic CPAP, you can see a mean correction in blood pressure of around 3.3 millimeters mercury in the second graph out here. Also, it makes a difference if one is sleepy or not. And in this particular study, they looked at changes in blood pressure, and here based on both your sleepiness as well as based on oxygen desaturation. The more likely you have to desaturate, the more likely you see a significant effect on your blood pressure. Similarly, if you're most likely to be sleepy, again, you're more likely to respond to CPAP. And that's something that we've seen in a few other studies. And this is just one of those studies that looked at, from Spain, looked at non-sleepy patients of 723 patients with no cardiovascular disease, and they selected these patients with an apnea-hypopnea index of 20 or higher, with an Epworth sleepiness scale of 10 or less. So these were clearly non-sleepy patients. And they were randomized to CPAP versus no intervention with a mean fall for about 4 years. The primary outcome was hypertension or cardiovascular event. And basically what they found was no significant reduction was noticed in either of these outcome measures, either of these primary outcome measures. And however, if you look at the post-hoc analysis, more than 4 hours of CPAP use did show an improvement in hypertension and some other cardiovascular events. So it's possible that the study might have been underpowered. But however, I think another study similarly showed, at least in non-sleepy patients, a reduction in blood pressure and cardiovascular event wasn't as robust as it was in sleepy patients. This is another study looking at a 9-week trial of CPAP in hypertensive, in patients with severe obstructive sleep apnea with an AHI more than 60 per minute, or 60 per hour, I'm sorry, with 2/3 being on antihypertensives. And the control group here was on subtherapeutic CPAP, so they weren't a complete sham group, meaning that these patients were receiving CPAP at a certain pressure, but not in the therapeutic range. And the reason for that is because, as you can see here, I just wanted to highlight, because they were on subtherapeutic, they still ended up having a reduction in your AHI by approximately 50%. There was a significant dropout rate of 47%, and the final conclusion of the study was that there was a BP reduction of around 10 millimeters mercury in the therapeutic CPAP compared to subtherapeutic CPAP. The point to keep in mind out here is this study did show with the reduction in AHI being about 50% in the subtherapeutic group, it also illustrates the point that it's very important to make sure that patients in the right pressure setting to control the sleep disorder breathing events completely. Otherwise, the likelihood of seeing a response may not be there, particularly in these patients with hypertension. What about the role of oxygen? So we just looked at CPAP so far. What about the role of oxygen in hypertension? So this study was done looking at 320 patients with an AHI between 15 and 50 per hour. And they were randomized to 3 different groups: CPAP, supplemental oxygen, and healthy lifestyle. And the primary outcome was a 24-hour mean blood pressure finding. And here, CPAP did decrease the blood pressure compared to the other groups, while supplemental oxygen had no effect on the blood pressure. Interestingly though, this was followed by another recent study that came out in 2018 this year, looking at supplemental oxygen on the effect, on blood pressure effect in patients with obstructive sleep apnea, called the SOX trial. So this was a randomized double-blind crossover trial, and they looked at patients after they were withdrawn from CPAP. So they had them on CPAP, they withdrew CPAP, placed oxygen, and they crossed over these patients. And the primary outcome was looking at a change in home AM or morning blood pressure readings. Interestingly, this particular study showed a drop in your systolic blood pressure by about 6 millimeters mercury compared to folks who are on room air. And the mean oxygen FiO2 that was given to these patients were between 2 to 4 liters per minute through nasal cannula. However, interestingly though, if you look at this trial closely, particularly if you look at these measures here, looking at the urine metanephrine, norepinephrine levels, there was no change. indicating that there's, from a biological possibility, the reason for why there was a reduction in blood pressure with oxygen is not entirely clear. So with the previous study showing no response, and with this study showing a response in blood pressure with the use of oxygen, again, one needs to be very careful in assuming that oxygen is the way to go to treat obstructive sleep apnea, because you're seeing a reduction in blood pressure. I think we just need more studies in this direction before we say oxygen is something that we could consider. I think you probably have seen studies that looked at OptiFlow or high-flow nasal oxygen, where there was a reduction in apnea-hypopnea index. Those studies would make a little sense, because there it's not just the oxygen alone, but also the pressure from the high flow that might give you a little bit of a CPAP effect that might help with your reduction in your apnea-hypopnea index. And this is not something that we would be seeing with oxygen at 4 liters per minute, for example. And so I think we just need to be careful in interpreting a study like this to say that this is the way to go for treating our obstructive sleep apnea patients. To summarize what we talked about from the hypertension point of things with obstructive sleep apnea, untreated OSA is a risk factor for hypertension, and inconsistent effects of CPAP therapy on blood pressure reduction. So you need to make sure that they are on the therapeutic amount of CPAP to be able to see a reduction in blood pressure. Patients who are sleepy are more likely to respond better to CPAP in terms of reduction in blood pressure and thereby cardiovascular events. The same clarity doesn't seem to exist for resistant hypertension, i.e. patients who are on more than 3 antihypertensives, or the data is again sparse in women and minorities, and that's something we need to keep an eye out for. However, if you're wanting to treat hypertension in patients who have obstructive sleep apnea, you may still need to go ahead and treat them with antihypertensives and not completely rely on to wait and see what happens when you start these patients on CPAP. So sometimes you might get a referral from primary care or from cardiovascular, from a cardiology folks to say, my patient's hypertensive, but he's also seems to be an obese gentleman who's got probably sleep disorder breathing. Even if you find out at an age of more than 40 per hour, it's better that you still not only get them on CPAP, but also refer them back to your cardiologist or primary care, saying that they still will need to be on some form of antihypertensive measures to help with your blood pressure control. What about heart failure? So the circulating catecholamine levels in these patients are higher, and particularly they tend to be higher as the heart failure severity increases. So as your EF or ejection fraction starts dipping down, the catecholamine levels tend to be higher. And of course, the higher the plasma levels of norepinephrine, the worse the prognosis is as well. And this is one of the reasons, of course, way back in the mid-90s, the rationale for beta blocker therapy for heart failure came into play as well. Interestingly, and this is something you might have noticed in your practice as well, heart failure patients with obstructive sleep apnea tend to be less sleepy than if they didn't have heart failure. And this is something to keep in mind, because both from a screening perspective and also from looking for symptoms in these patients, you may not want to necessarily depend on daytime sleepiness as a way to figure out if this is something that you may want to screen these patients for. And of course, the speculation out here is this might be the increased noradrenaline levels or catecholamine levels that might make these patients a little less sleepy compared to those obstructive sleep apnea patients without heart failure. And there is bidirectionality to this, where heart failure may also predispose to obstructive sleep apnea, and obstructive sleep apnea, if left untreated for a period of time, could also lead to heart failure. And the former, where heart failure may predispose to obstructive sleep apnea, is based on a few studies, and this is where they did some experimental manipulation of CVP by applying some constriction to the lower legs, so thereby preventing any third spacing and diverting the fluid from extravascular to intravascular, and they found rostral fluid shifts happening. In fact, it even leading to increased neck circumference, and doing a pre and post measurement of this, they found increased apnea-hypopnea index as well in these patients. So it's suggesting that the the presence of fluid in the setting of heart failure might increase one's risk for obstructive sleep apnea. In fact, there's biological possibility to that as well, because when you give these subjects intensive diuretic therapy, you can see a significant reduction in the apnea-hypopnea index pre and post diuresis. And this is looking at this neck circumference, where basically the modified version of neck circumference looking at the oral airway inside. You can see an improvement in the airway because of an increase in neck circumference as the diuresis happen. This is just to show you an example of what one of our patients in the hospital practice, where we did an overnight oximetry study at the top here. And this is, as you can see, significant oscillating desaturation suggested for significant sleep disordered breathing. And then we diuresed this patient, and 3 days later repeated another oximetry study, and this almost looks normal. So again, the bottom line, the take-home point out here is, if you see patients with heart failure in the hospital, before you do a sleep study, you may want to make sure that they are well diuresed and in a chronic stable heart failure setting before you want to screen them for obstructive sleep apnea. Some of the trials of CPAP and heart failure, and this is one such trial in 2003, which showed an increase in the ejection fraction by about 9% pre and post CPAP treatment. And this probably goes back to what we talked about in terms of what happens with the intrathoracic pressure swings in a few slides beforehand. So we talked about obstructive sleep apnea causing increased transmyocardial pressure gradient and increase in one's afterload. And if you give CPAP, you're quickly reducing your pleural pressure from -80 to -5 to +5, depending on the amount of CPAP that you end up using. And that will quickly reduce your afterload. And as your afterload decreases and your transmyocardial pressure gradient improves, your ejection fraction might improve as well. So there's possible reasons why, with the use of CPAP in obstructive sleep apnea, you have heart failure, there might be an improvement in your ejection fraction. Also, it's important to notice that heart failure patients who have untreated obstructive sleep apnea, they have a worse survival compared to those who have treated, and as shown out here. These are the patients with obstructive sleep apnea with heart failure who were treated, and these were the ones who were untreated. And another good reason to treat these patients with CPAP. What about cardiac arrhythmias? So just go back to the scoring manual. As we talked about earlier, looking at we use only one lead, and the lead ideally should be lead 2, so that way you can look for changes in your sinus beats as well as for any particular arrhythmias. And this is actually a real patient that we had who had a 32nd epoch in a 74-year-old with underlying cardiac disease with an AICD in place. And this happened during stage N2 and the heart rate in the 70s. And I think the question is what type of arrhythmia is this? And in this case, for time's sake, I'm just going to say that this was a wide complex tachycardia. The answer is going to be number 4. And I'll explain why it might be wide complex and not one of the others in a second here. So wide complex tachycardia, again, if you look at the scoring manual, it says that for rhythm lasting for minimum of 3 consecutive beats at a rate greater than 100 beats per minute, with a QRS duration of greater than or equal to 120 milliseconds. And that clearly fits the criteria for calling it a wide complex tachycardia in this particular subject, where you definitely have more than 3 consecutive beats, the QRS duration is more than 120 milliseconds, and it's at a rate of more than 100 beats per minute. So in that case, it becomes a wide complex tachycardia. And as we talked about, you need to make the origin of the wide complex tachycardia might then tell you whether it's a VTAC or if it's something else. And if for time's sake again, if the axis is different, so if you have an axis that's completely opposite to the previous QRS complex, then it's probably going to be a ventricular tachycardia. If it's the same complex, if it's in the same direction as the previous QRS complex, then though it could still be a VTAC, the likelihood then of this wide complex tachycardia being another abnormal rhythm might increase at that particular stage. So extreme axis deviation with a wide QRS in a single lead EKG, suspect that this could be a VTAC. This is just to show you an example of a patient with a VTAC. At least likely this was an uncystic VTAC. But you can see the QRS is in a different axis compared to the wide complex tachycardia over here. So this is, though technically it would be called as a wide complex tachycardia, among the wide complex tachycardia this is more likely to be a VTAC because of the axis being completely different. Diving reflex is something that you can see with obstructive sleep apnea. Again, what is diving reflex? This is something that you would see with diving mammals because when they dive and go under water, they are apneic, and during the apneic episode, for survival reasons, they have increased sympathetic drive peripherally so that there's vasoconstriction of the peripheries, diverting blood away from the limbs so that that blood can go to the heart and the brain. At the same time, we have increased vagal efference to the heart so that there's bradycardia to preserve the heart, so to say, and divert whatever blood is coming to the heart to the brain so that it's a preservative mechanism for diving mammals. So this is something that you would see in patients with severe obstructive sleep apnea where we have increased vagal efference to the heart causing sinus bradycardia, sometimes even to the point that they might develop a block, and increased sympathetic drive to the peripheries causing peripheral vasoconstriction. And of course, a few things to keep in mind with ST segment depression. Again, be very careful interpreting ST segment depression in patients who seem to exhibit that with a single lead EKG on your PSG. And for time's sake, I may not be able to go through the various differences out here, but